With regards to newly diagnosed multiple myeloma, I think it's safe to say that lenalidomide with a proteasome inhibitor and dexamethasone represents the standard of care for treatment of these particular patients. I think that there's some very interesting recent data, that have been published, expanding on that. In particular, I think that the endurance trial, which looked at lenalidomide, bortezomib, and dexamethasone versus lenalidomide, carfilzomib, and dexamethasone for newly diagnosed myeloma patients who are not intending to go through frontline stem cell transplant. These data have already been published and showed really no difference with regards to progression-free or overall survival in the two arms of the trial. So carfilzomib was not able to clearly outperform bortezomib in that particular setting. However, the data with the addition of daratumumab into the lenalidomide or thalidomide, bortezomib dexamethasone backbone in newly diagnosed myeloma patients is very promising. So the Cassiopeia trial is a phase 3 study that incorporated daratumumab into the VTD backbone for transplant-eligible multiple myeloma patients. And in that particular study, they showed not only an improvement of depth of response with the addition of daratumumab into the regimen, but an improvement in median progression-free survival. And as a result, that led to regulatory approvals of that particular four-drug combination for transplant-eligible myeloma patients. The Griffin trial, which we'll talk more about, incorporated daratumumab into the RVD backbone in transplant-eligible patients. And we've shown in that study to date that not only are we seeing an improvement in depth of response, but sustained deep responses in the daratumumab arm. In the relapsed refractory setting, there's a lot going on. I would say that a variety of different immunotherapy approaches are the most encouraging, and we'll see a lot of this at ASH this year, which is very exciting. The chimeric antigen receptor T cell data continues to impress, and we'll see more updates at this year's ASH in that regard. I think we're getting additional data, that are being presented on the use of bispecific antibodies in relapsed refractory multiple myeloma. Most of the CAR T cell and bispecific studies that have been, presented or published to date are targeting a plasma cell specific marker called BCMA. But at this year's ASH, there's going to be novel targets that are going to be the subject of oral presentations. So, for example, talquetamab is a bispecific antibody that targets a relatively plasma cell specific marker called GPRC5D. And we're going to see very exciting data with that bispecific antibody in relapsed refractory multiple myeloma patients at this year's ASH. There's also another target called FCRH5, again, another relatively plasma cell specific marker. And we're going to see very interesting data with the bispecific antibody targeting that particular, cell surface plasma cell marker at this year's ASH, and that should be very exciting. So I would argue that the bispecific antibodies and CAR T cell therapies are definitely the most exciting areas in the relapsed refractory landscape.